All right, everybody, it looks like we have a couple more people who just joined us on the webinar portion, so I'm going to get us started. So today's just going to be a quick little presentation on let me back up. First of all, how this came about is we did a baseline, as all of you know, for the Patient Safety Culture Survey among the Wyoming Critical Access Hospitals, and there were an original 5 that participated, and now an additional 4, possibly 6 are going to be participating. And as a result of the baseline data from all of the participants, among all of those that are, we have baseline data for, the handoffs and transitions was the lowest domain or measure for improvement. So today we will be having just the first of several 30-minute quality improvement webinars towards improving the patient safety survey results and the measures. So I have some, I'm not going to make my screen big yet. I have some quick little videos that I'm going to do in today's presentation, so bear with me. They're only literally a couple minutes long each to get off my point here. To help improve handoffs and transitions, I'm going to focus today on SBAR to help improving the communication, whether it's in between departments or just in between shift changes and so on and so forth. How we're going to move forward with these webinar series is that it's going to be a 30-minute webinar series on each topic, but there's going to be 2. So today's webinar is going to be on one method or approach to improve handoffs and transitions, and then in 2 weeks we'll have another one, which will be April 6th, every 2 weeks on a Thursday. And I was going to ask you at the end of the call about a time frame that might be better than the 11 to 11:30, because I'm thinking more along a lunch and learn session, but again, so hold your thoughts on that. But then the next webinar on April 3rd will again be a quick little 30-minute webinar, and it will be either on a facility quickly sharing the best practices as to how well they're doing in their handoffs and transitions and why they have been so successful, and then 2, maybe possibly another little quick implementation tool that you can use in case you're not in favor of SBAR. And then from that, 2 weeks from April 6th, we will start a different topic, and then we will do 2 30-minute webinars on that topic. And so the next Save the Date that will be going out this week will actually have all of the dates for all the upcoming webinars throughout the rest of the summer. So stay tuned for that. So I'm going to share my desktop and see if we can't go to my recording. And I hope this works really well without any background issues with my speakers on my computer and putting this on the phone. So I apologize if it's kind of a little rocky at first.
I'm going to tell you a story about a 41-year-old lady who came to the ED with mental status changes. She was diagnosed with a urinary tract infection, and she was placed on antibiotics. Her physical exam overall was pretty unremarkable. She was alert to person, but that was really about it. Her labs showed that she had anemia and she had hematuria. Her platelets were pending. She was admitted to the internal medicine service, and there were no beds available, so she became a boarding patient in the ED. The outgoing physician completed all documentation and really signed out care of this patient to the internal medicine physician. 4 hours after this patient arrived to the hospital, lab calls back with a critical result. Her platelets are now 4,000. This was not discovered. 16 hours after the patient's arrival to the hospital, the internal medicine physician noticed the patient's low platelets. The patient was then transferred to the ICU. She did have a plasma exchange, but she died from this adverse outcome. It clearly was a failure in handoff and communication. So what happened? A couple of things. First, the change of shift handover was really very brief. It was unclear who was responsible for the follow-up of this patient. Was it the ED physician who was just coming on, or was it the internal medicine physician who was actually the attending for this patient? When the diagnosis was made, the thinking really stopped. There was no independent evaluation by the ED physician who was oncoming. When this patient became a boarding patient, it was very unclear who was responsible for follow-up. The other issue was communication, and that failure really prevented ongoing treatment. When the unit secretary received that platelet result of 4,000, who did she tell? What's the protocol? What's the expectation in regards to follow-up? Who should have taken that critical test result? The unit coordinator did not remember who she told about that result.
Handoffs are about the transfer of care and critical information between one provider to another. A common misconception there would be that it only applies to change of shift between one emergency physician to another. But there are lots of opportunities for mistakes to happen in the emergency department. Clear communication about a patient can happen between an EMS provider and a nurse, between two nurses that change a shift, between two physicians, one a consultant or the admitting physician. So there's lots of opportunity for failures of communication. Now, from the risk elements, there are a couple of critical factors. It really behooves the oncoming physician to do an independent evaluation. In other words, listen to the story, hear all the facts that have been ascertained, but approach the patient with a fresh set of eyes, if you will. The second step is really accessing and making sure that critical data points, critical information is communicated to the oncoming team or oncoming physician. When we see delays or failure, it is about frequently labs, x-ray results, or additional history which is obtained, such as an old EKG that's not communicated to the ongoing team. Fortunately, there are many new solutions and creative solutions that lead to improved communication and reduction of handoffs. A lot of them revolve around technology, so the ability to, for example, text or use social media or types of prompts, the ability to look at a tracking board where critical lab values are flagged, and that information is communicated to the ongoing team. Some of the other techniques that are used are to decrease the amount of interruptions, particularly during the transfer of care process, and also to label and tag with colored areas or blinking areas, for example, on a tracking board, critical values or critical times. For example, the fact that a patient had been waiting in the emergency room 4 hours post-admission. Those kinds of cues and prompts lend themselves to technology, but there is no substitute for enhanced communication than face-to-face interaction. Face-to-face communication is critical in ensuring that handoffs are both timely and accurate in terms of information communicated. The best example of that is actually to do formal sign-out rounds and to bring the oncoming provider, introduce them to the patient, address any of the patient's concerns, and make sure that critical data elements are being followed up on. There's no substitute for looking somebody in the eye and having that communication, and also having them repeat back to you what it is that you're concerned about and what things they need to follow up. A good example of that would be simply saying, hey, can you check on the labs on bed 5? I think they just have a UTI, as opposed to saying, this is a patient that arrived presented with acute urinary tract infection. However, on exam, some confusion was noted, and we're waiting for some critical lab values, including following up on the patient's anemia. In the end, handoffs are all about proper communication and transfer of care.
Okay, so that actually worked pretty well. I'm impressed with myself, I must say. Okay, so I'm going back to my presentation. And for those of you on the call and also on the webinar, I included the links in the handouts for these quick little tutorials that I'm sharing in case you're interested. So we're going to get back into the presentation. So just some background, the Safety Attitudes Questionnaire from Kaiser Permanente administered SBAR. They identified that physician and nurse perceptions of teamwork were significantly different, and physicians tended to view the care environment as fairly collaborative, whereas nurses saw it as much less so, and so on and so forth. So to address this, Kaiser Permanente developed a communication tool that was adapted from the U.S. Navy called SBAR, and then from there it has been adapted for quite some time into the healthcare setting. So SBAR is actually an acronym, as most of you are probably very familiar with it. It's an acronym for Situation, Background, Assessment, and Recommendation. So It's a technique that can be used to facilitate prompt and appropriate communication, and this communication model has gained popularity in healthcare settings, especially among professions such as physicians and nursing. So it's a communication tool that provides a method of clearly communicating the pertinent information from a clinical encounter and empowers all members of the healthcare team to provide their input into the patient situation, including recommendations. And then assessment and recommendation phases within the SBAR steps provide an opportunity for discussion among the members of the healthcare team. And, you know, I've worked with a couple facilities in other states in implementing this in their facility, and it does come across with some as not being very comfortable at first for either the sender or the receiver of the information, but what's great about it is it helps improve the effectiveness of the communication between individuals. So having one standardized approach for communicating makes it so easy to use and can help staff learn the key components needed to send a complete message. So that being said, let's get into a little bit about what each section is. So why do you need SBAR? Well, the situation for S is a concise statement of the problem. And so why do we need this? Because poor communication, errors, callbacks from clinical and clerical staff to get more pertinent information. Background, which is about the pertinent and brief information related to the situation. There are barriers such as training on communication styles that vary between person to person. There's a lack of assertiveness between hierarchy. There's distractions, which causes missing information from sign-offs. Then there's A for assessment, which is about the analysis and the considerations of options, like what you found and what you think. So we need this new communication style one that is common within your organization that all healthcare professionals and team members can use. And then our recommendation, it's action requested and recommended, like what do you want and does the other person agree? And are they repeating it back to you that they understand it? So the SBAR is a simple tool that is shown to effectively improve communication that will decrease error and has been effectively applied within healthcare. So I'm going to go over some examples here in the next couple slides, and then I have literally like two 50-second videos to show you the difference between poor communication and effective communication, one using SBAR and then, of course, one without SBAR. So SBAR is easy to remember. It's a standardized approach that promotes efficient transfer of key information. It helps create an environment that allows staff to express their concerns, and it clarifies what information needs communicated quickly, and it points to action. So what you're going to do, and I have, again, these tools, and I'm going to zip them and send them out to you, but I know some of the firewalls actually block that, so I got to find a way to make the files smaller so that they'll actually go through to some of your emails. But anyways, clearly, so for the situation, in some of these examples, you're going to show how people are clearly and briefly defining the situation. So just an example is, Mr. Jones has multiple prescriptions of Coumadin. He is home, and he is unclear as to which one he is supposed to take. Background, you need to provide clear, relevant background information that relates to the situation. You should consider using the patient's diagnosis, the prescribing physician, and the dates and dosages of the medications. So assessment is just a statement of your professional conclusion of the patient and what's going on. And then the recommendation is, what do you need from this individual? So another example would be, please clarify which is the correct dose of Coumadin for Mr. Jones to take and which physician will be responsible for managing his anticoagulant therapy. So here, these next couple of slides literally break it down for you. So outside the one-page spreadsheet or protocol that I'm going to share with you, this actually breaks it down into the slides so that you have them. So quickly, situation, you're going to identify yourself and your patient, what's going on with the patient, and what the cause is for concern, and just a concise statement of the problem. So guideline number 2 for background, you're going to give the quick clinical background information that is pertinent to the situation, whether it's the diagnosis, list of medications and allergies, any recent vitals, any recent labs, a very brief medical history of any pertinent information that relates to the situation, and then your findings and thoughts on what's going on. And then the assessment, sorry, I kind of jumped ahead, but the assessment, those kind of the B and the A and SBAR actually kind of go back to back and kind of can, intermingle, but you want to know the results of the clinical assessment. What are the clinical findings, the analysis and consideration of options, and is the problem severe or life-threatening? And then from there you go into the recommendation. What do you want to happen and by when? What action and recommendation is needed to correct the problem? What solution can you offer? What do you need from the physician or nurse or staff? Because again, this isn't just for nurse and physician communication or physician to physician. It could be between departments. It can be between just a nurse and nurse. It could be like a bedside handoff. It could be an ER handoff. It could be an admitting. I mean, there are so many different scenarios where this actually works. And then, of course, lastly, what time frame do you expect this action to take place? So here's a written example, and then I'm going to hop into the videos. So a parent of a patient calls, "Hi, I'm calling in regards to my son, Georgie Porgy. His date of birth is January 12, 2005. He has had diarrhea for about 4 days now, and when he woke up this morning, he had a fever of about 101.2. I would like to speak to a nurse about this if they are available." So using SBAR in a quick text, so the situation, Mom, Marge Porgy, would like to speak with the triage nurse. Patient has had diarrhea for 4 days and woke up this morning with a fever of over 101. Background, spoke with the nurse on January 25th in regards to the diarrhea. Assessment, information sent to triage for evaluation. Recommendation, please call Mom back at cell phone number 5555555. So it's just taking the information that you have and just putting it in a simple, clear format. I mean, as you can see, like, you can get paragraphs of information, and when you use the SBAR technique, you can literally break it down into a sentence or two across each one of these and do a handoff within less than 5 minutes. Some of the case studies on SBAR show that it is such an easy tool to remember and to utilize that, I mean, while it can take some time to implement in your facility, when it comes to teaching staff how to use it, it's so quick for them to pick up on it that, I mean, the studies have shown it can take about 15 minutes just to go over using SBAR and how to use it, and for them to remember it because it is such a simple and easy tool. However, of course, when it comes to your facility, it's going to vary by how you can actually implement it between departments and how you can get the staff to actually understand it and use it. The understanding is one part, but actually getting them to use it on a regular basis, that's where the challenge may lie for you and where it may take a little bit more time. So now I'm going to actually go back real fast, like share my desktop. So here's just a quick video on ineffective communication not using SBAR. It's like less than a minute.
Oh, hi, Dr. McCarthy. Do you have a second? Second? Sorry, I just wanted to talk about Mrs. Holmes. What's up? Well, I spoke with nursing after rounds today. I was wondering if we should change her pain medication.
I'm sorry, who are you?
Oh, I'm John, the pharmacist on the stroke unit while Tanya's away.
Why change her medication, John? Why wouldn't we just up the dose?
Well, the current med isn't fully relieving her pain, and the team says it's making her drowsy, too tired for her therapies. She's reporting her pain at 7 out of 10 for the last,
Okay, what are you suggesting?
Well, I don't really know this patient very well. I could review her chart, but that might take a while. I'm not going to be here tomorrow. Tanya's coming back, so maybe this should wait. But Mrs. Holmes is really hoping to be home for the weekend, some big anniversary, and her husband is coming in this Thursday, so maybe one of us should talk with him.
Okay.
Okay, so not very effective communication and not working very well for the patient. So here is a perfect example of effective communication using SBAR for pretty much the same situation.
Hi, Dr. McCarthy. Is this a good time? I need 3 minutes to discuss Mrs. Holmes. I'm John. I'm providing pharmacy coverage to the unit.
I have a few minutes. What's up?
Nursing raised a concern from rounds this morning. The situation is that Mrs. Holmes' pain isn't being well controlled. She's sedated, which is having an impact on her participation in therapies, and she's continually reporting her pain at 7 out of 10. Now, the background is that she's fallen 3 times since her admission to rehab, and she's requesting to go home at her first pass this weekend, some big family anniversary. But my assessment is that we are not adequately controlling her pain, and what we're giving her is contributing to these falls.
Okay, so what do you recommend?
Well, after reviewing her chart, I'm considering lowering her dose of opiates and introducing an anti-inflammatory, which would be less sedating, and she should be able to tolerate.
Yeah, that makes sense.
Her husband is coming in this Thursday at 10. If you're available, we could meet to discuss.
Okay, sounds like a good plan. Let's meet back here, and we'll talk to the family together.
So both, obviously, in both scenarios, the ineffective communication not using SBAR was less than a minute, and the effective communication using SBAR was, again, less than a minute. So using the tool itself doesn't actually delay communicating of information. So I am going to skip ahead. I just put that in an algorithm, but I mean, the presentation in terms of the videos pretty much explain it a lot better than actually going through an algorithm. But what I want to show you now is the information that I'm going to be sending out in a zip tool. It provides all the information. It's actually an SBAR bundle package that came from the Institute for Healthcare Improvement. It has the actual communication tool itself, kind of like a generic report for physicians, a generic report between nursing on sign-offs and sign-out rounds, lesson plans, a checkoff list, some poster examples, some sticker templates that you can use, as well as some tips for when to use SBAR or how to go about using SBAR in different situations, whether it's nurse to nurse, nurse to physician, physician to physician, in between departments, and so on. So what I'm actually going to do is share my desktop one more time and actually show you these tools real fast, because I have them all up. Oh, wrong screen. There we go. So these are all the tools that are going to be in the bundle that I'm going to send you. So here is an actual handout on how to do SBAR, an actual template. It gives you the situation, the background, the assessment, and the recommendation, and it literally provides the information. This can obviously be modified. It's in a Word template. I'm showing it in PDF, but I can send it in a Word template so you can modify it to fit your organization. There's also some samples and definitions when you're sharing this with staff or trying to implement it in your facility as to what each item is, an example of how to use it. There are some sticker templates that you can use. I know a lot of us are going to the EHR, but if you do have those paper sign-out rounds that you're still utilizing, these stickers could be very helpful. There's also a tip sheet. Just the bundle in and of itself, and this checkoff actually is one of my favorite, but this has everything you will need to implement this in your facility. I know some facilities have tried SBAR, are currently using SBAR, but what I would like from you on the call is to try this out in your facility and give me some feedback, because it has shown, and I can send case studies if you want additional information, please just email me anytime after this presentation. The case studies have shown that it has directly impacted specifically the ARC patient safety culture handoffs and transitions section of the patient safety culture survey. So again, I would like for you guys to try and use this template in a couple scenarios at your facility. Maybe take it to your quality committee, your quality department, see if it's something that you guys would be willing to give a try at your facility. And then I would be really interested to hear back from you on how it's working or not working, because that's what I need to know when we're doing these quick little QI activities. If something isn't working for your facility, I need to know so that we can try a different approach. There are other techniques outside of SBAR. There's a new one that came out from the Joint Commission, and I'm forgetting the acronym right now, and there's also an additional, some of you nurses might be more familiar with the acronym SOAP. Again, it's another communication technique. So with these tools that I'm going to be sending to each facility who is participating in the Patient Safety Culture Survey, I would like to have you take time to look over these materials, reach out to me if you have questions, because I will be reaching out to you as a follow-up to this webinar to see about how we could implement it at your facility or to address any questions, concerns, or barriers you might be having, and so on. Going back to the presentation, I have included links for everything. The first link on this presentation will take you to the page all about SBAR on the IHA website, and it actually has all these individual tools out there that I have linked as well. Just in case those links don't work, you can get taken to the main page. And that is it. One thing before we go that I want to ask you is, one, when we move forward with these QI activities, is 11 to 11:30 a good time for you to? I was trying to do the 11 to 11:30 to kind of keep it around lunchtime, so it could be like a lunch and learn. Or I would appreciate your feedback to see if there is a different time of day that you think is better. Lori, Piper, Sheila, anybody else on the line? Do you have any thoughts on that, or does 11 to 11:30 typically work?
Chanel, I'm sorry. I got interrupted just briefly, and it's Kyle, and I'm back on. I'm sorry.
Oh, okay. Thank you, Kyle.
This is Piper, and that time works good for me.
Okay. Awesome. Thank you, Piper.
So, Chanel, I think I might have missed something because I had an interruption, but can I ask a question? And then if I can get feedback from participants, that'd be really helpful.
Yeah, go ahead.
Okay. So this seems like it really works well, but anytime we introduce something new, there's always that time where there's people who will either buy in automatically or who won't buy in at all. So do you have, and maybe you already covered this, but do you have a suggestion about how we go about just beginning to introduce this concept of SBAR to our coworkers and certainly the CEO, the administration?
So there's a couple ways to go about it. It all varies, of course, by how, I guess, the culture is in each facility right now. So one, they could go as far as to introduce it themselves. If they're just, like, let's say it's just a nurse on the call today or just for their facility, they could go in with introducing it in their department as like a small little implementation or intervention. So like the quality department could introduce it and start using it, or they could take it to their quality committee and talk to the quality committee about it, and then try to have members of the quality committee try to introduce it in their departments, whether it's like within the pharmacy or within the nursing unit or within the ER or so on, just so it starts in one tiny unit, and then get feedback and see how it's actually working, if it's working, and what kind of barriers they're running into, rather than obviously like implementing it like facility-wide. There are some facilities who, when they have implemented it, they've just started small with one department, and then once they've got all the bugs figured out, got the feedback from the staff, they actually will roll it out facility-wide and actually develop like policies and procedures for this to be their communication tool in their facility when they are doing handoffs and transitions between departments, and either at the bedside or admission or ER to inpatient, or just handoffs from shift changes and so on. So I do, inside the packet, the bundle, there is a document that actually talks about the implementation guide and what-if scenarios and how to go about doing it.
I really appreciate that, and I agree. So even at one of the nurses, just one nurse's station, if those people who work at that nurse's station say, we're going to try this for the next 30 days and see what happens, that's a great way just to plant the seed rather than to try to grow the whole garden right away.
Yes, absolutely. That's very well said, actually.
Yeah.
So, I mean, we're looking at about 11:29 right now. Are there any questions about what I went over today? I know it was really brief, but we're trying a new technique, trying to just do quick little webinars rather than long webinars because of the burnout we're hearing. Everybody's saying they're overwhelmed by so many webinars. So we're trying a quicker approach to make them short, to the point, giving you information that has been proven effective that you can use and implement in your facility. So one thing that we may try then on the next call is, depending on the feedback I get from you guys, is to address any barriers with implementation or maybe dig a little bit more into the implementation of SBAR, and then we can have a facility actually share for a few minutes why they're doing so well on handoffs and communication and transitions using SBAR. So we'll share a best practice from a facility on the next call, and we'll talk about implementation.
I like that. I think that's a great idea. And then just real quickly, if you get negative feedback, do you also have suggestions on how to overcome those negative? Why do we need to do this? What we've always been doing is already working. I don't really see that there's a problem. Do you have any? And maybe we can cover that the next webinar because we do want to keep it.
Yes, I definitely have stuff to address negative feedback or people who are not wanting to buy in. There is information out on IHI on how to address some of that, whether it's sharing guidelines of proven effectiveness to sharing the data showing them that at their facility what they're using, or if they're not using anything at all, is not working, and so on. So yeah, we can definitely dig into that further on the next call if that's the feedback, or if people are getting a lot of negative or pushback from their facility. We can definitely address that as needed. Thank you, Kyle. Are there any other questions? Okay. Well, with that being said, I'm going to stop the meeting. It was recorded, so within a couple days, the recording and I'm going to send the bundle out right away. The recording will be out in the next couple of days along with additional handouts just in case. And then feel free to contact me directly so that we can work one-on-one about this and implementing it in your facility. If you have any questions, concerns, or how you want to go about it, I can work with you one-on-one to address your facility's individual needs. And then stay tuned for the emails to come out from me. And then the next webinar, which will be the second piece to this, will be April 6th, and it will be from 11 to 11:30. Thank you, everybody, for calling in and participating. It's greatly appreciated, and I will be in touch.
Thank you, Chanel. You did great.
All right. Thanks, Kyle.